the decision would be made by the hospitals as to where the placement would be, and that would change the discretion of the courts.
The system that was proposed by the Department of State Hospitals, where there's a conversation between the judiciary and the hospitals, would still be able to exist, but the discretion would be with the state hospitals for the initial placement.
All right. Thank you very much. Department of Finance? All right, members? Senator Monty?
So I'm just curious again to reconcile. I followed your explanation of vacant beds based on classification and matching patient to needed care. With my understanding is Coleman patients have been sentenced to a prison sentence and then due to mental health issues are assigned to placement in one of the state hospitals. Is that accurate?
Yes, it is.
What's the current, is there a waiting list for Coleman transfers from state prisons to hospital facilities?
Yes, there is currently a waiting list.
And do you know how large that waiting list is?
I want to say it's...
Good morning, this is Pam Allen, Department of State Hospitals. It's currently around 60 right now, and we are meeting the time frames to getting them in within the ICF beds and the acute beds.
And then just to help with my education, Coleman classification is somebody who's already been sentenced to prison. So somebody being held in a county jail, awaiting trial, but manifesting mental health crisis, are they eligible for a transfer pending trial?
The Coleman patients we accept them directly from California Department of Corrections. They're committed there.
Right.
The other pending placements are in county jails, such as ISTs, incompetent to stand trials. So we have two different pending placement lists that come from two different systems, one Department of Corrections and one from the county jails.
Great. So the county jail then would be an IST classification?
Correct.
Potentially? And do you know, is there a waiting list for those placements?
Yes, we have approximately 308 sitting, a total, 308 waiting to come into our system right now.
And is there anything in the planning or the budget proposals that helps relieve that backlog?
Yes, it's number 4 on your agenda today.
Great. Thank you.
All right. Thank you very much. Is there any public comment on this item? All right. Well, I do have one last question on this item 3. When can we expect to get the proposed trailer bill language for this budget item?
We currently have some language in draft, and we're happy to meet with your staff and talk about that language.
Yes. How soon would that be?
We could probably do it within the next 2 weeks.
Okay. Thank you very much. All right. Next item is the incompetent to stand trial waiting list. I know we talked about that briefly. We could have some more details
I'll
on
let
that.
Pam Allen deal with that issue, who is our new chief deputy as of January. We're very happy to have her.
Welcome aboard.
Well, thank you. Okay, it's very similar to what Mark was talking about as far as our pending list. We have 308 sitting out in county jails right now waiting to come into our system. I'll go straight to the questions that you had. Does the length of waiting list vary from month to month? If so, please provide the subcommittee with data on the last 12 to 24 months. We have an attachment that should be passed out. And this is attachment A. And it identifies July 2012 to March of 2014, and it shows the average pending placements. And we've gone from 222 back in July of 2012 to currently 423, and that is all pending placements. If you go up to the ISTs, you can see we have 308 as of March 2014. Question number 2, how many ISTs are left by counties at State Hospital? After the competency, we have another attachment. We have that one attachment? Okay, we don't have that. It's attached. We have, let me get my list. Approximately, I think there's 38 that are left. We had 100. We don't have an attachment for that.
Do we have one for that? Yes?
No, there's not an attachment
Okay.
for that particular one. What we had was, when we started this in July of 2013, looking at those that were unlikely to be restored and sitting in our state hospital system, we had 109. As of today, we have 35 that are sitting in our system that are waiting to go back to county jail that are unlikely. They break down into 2 categories. One are patients that are determined unable to restore due to mental competency, and then we also have those that have not been restored within the 3-year time frame. So I believe there is 4 of the ones that are unlikely underneath the 3-year time limit, and 31 that are exceeding the 3-year time frame. Question number 3, is there a problem with certain counties? Not particularly. LA County is a very large county, and 22 of the patients reside in LA County. Some of the steps that we've done to mitigate this from July of 2013 to current is we did it in phase 1. We did the initial count and looking at and breaking it down to what patients were beyond 3 years and what patients were under 3 years. Phase 2 was our legal department did an outreach to every county where those were found to be, and started talking with the public defender, and that resulted in some of the patients being picked up and taken back to the county for their court hearing. Another phase 3, we created templates and we filed motions in the court, and that was resolved, a lot of them as well. Some of these 31 patients that are still residing in our problem, hospitals are waiting to go for conservatorship. So we believe we have some legislation going forward as well to have them picked up within 10 days of being unlikely to be restored, so they can go through the court process sooner.
Can you help us understand a little bit more why people are not being retrieved, brought back to their counties? Retrieved is not a very nice word, but being brought back to their counties.
Right.
And many times it's because the county does not have the capacity to deal with the patients. And it's their ability to really deal with them. They are incompetent. The conservatorship process, as you know, can sometimes be difficult and can take time. We think that if we can work out a middle ground so that we assist the counties in making that judgment earlier that they are not competent, and assist the county in engaging in the conservatorship at an earlier point, that we might be able to reduce that problem. But that's part of the legislation that we have under consideration.
So the individual may remain incompetent, but so you can't really place them back in the county jail. Is that the idea? So the conservatorship will help with that. All right. Thank you very much. All right.
Okay, has administration considered charging a per day? I don't think we've considered that this time.
We believe the first step should be to have statutory determination of time. Excuse me, that if that doesn't work, then it is possible that we could come back. But if the statute says 10 days, it should be followed by the counties.
Okay, and then we go into, has the administration done an inventory and analysis? And yes, we have. We've gone through our total system of all the hospitals to analyze our beds by commitment within all of the 5 standalone state hospitals. And part of our recommendation is the 105 additional beds at Kalinga State Hospital, where we already have vacant units available, and that we are going to transfer mentally disordered offenders from 4 existing hospitals that treat incompetent to stand trial patients to Kalinga, where we're able to recruit and staff those units, get them up and running. And then that will allow for us to backfill from Patton State Hospital, Metro State Hospital, Napa State Hospital, and Atascadero to, again, serve those surrounding counties for the incompetent to stand trial, again, keeping them close to their county of commitment. So that will allow 105 beds to be served for the 308 that are sitting on the list.
One other thing that we're doing, we had a program that was a pilot program a few years ago in San Bernardino County where the competency would be done in the jails. It has proven to be successful, and the reason it is successful is that the judgment is made at the jail based on their ability to basically gain competency quicker in a jail than having them basically go to a hospital, because there's a lot of it is a lot lost, and we have tried to expand the program. We're in discussion with Los Angeles County, Sacramento County, and Alameda County, and there are a number of other counties who have expressed interest. And if we're able to basically engage those counties to provide the services at the jail, the waiting list would be substantially reduced.
All right. Can I go back and ask a question about the inventory and the analysis? When was that done, and has that been made available to the committee yet?
Yeah, we could make that available. We started that in February of looking at why the wait list was where it was at. When I started in January, came in and looked at this. Did an analysis of, again, the vacant beds. Where are they at? What are they? Admission beds? Are they short-term beds? Are they long-term beds? And then broke them down by hospitals. And then we took the existing pending placement list, because those are broken down by hospital. Napa has their own list. Patton has their own list based on the counties that normally commit to them, and looked at what their vacancy rate was in their long-term beds, and then also if they had enough admission beds and discharge beds as well. So we have that analysis available if you'd like to see that.
Okay, thank you very much. If you could provide that, that would be helpful.
Sure.
Thank you very much. All right, anything else on this item? Yes, Legislative Analyst's Office. Thank you.
Thank you very much, Madam Chair. Since our concern for both of the population proposals are very similar, I'll address them both together, and then if you have any questions specific to CDCR, we can address those later. So our office is recommending that the legislature reject this proposal at the current time and request additional information from the department about its ongoing needs. And this is for two main reasons. First, we're unclear whether the current budget is the appropriate size or whether savings could offset the requested increases. And second, we're also concerned about the high staff vacancy rates, which could affect the department's ability to fill newly budgeted beds. Our office is also recommending that DSH contract for an analytically based assessment of their distribution of beds and staffing. While we acknowledge that there's been an increase in the patient wait list, we have concerns that this proposal may not be an accurate assessment of the precise needs of the department. So while there's been an increase recently in those referrals, the department is currently budgeted through the state hospitals and in the psychiatric programs at CDCR for approximately 500 beds that are not being used. And we do recognize, as the department noted, that some of those beds are reserved for certain purposes, but there does appear to be a consistent over budgeting. And because annual per patient costs exceed $200,000, that can represent a substantial amount of savings. In addition, the number of vacant beds does fluctuate, which seems to indicate that the department can operate with a varying number of vacant beds. This kind of leads us into our bigger recommendation, which is that we're concerned that the department doesn't have an independently developed vacancy or staffing model. And we would point kind of to the Department of Corrections. For example, their staffing model includes factors like evidence-based ratios of patients to providers, the number of vacant beds that are necessary and how those vacant beds should be staffed and budgeted, the appropriate distribution of the various bed types. So for example, the department's mentioned that they've done analyses of how many vacant beds they have for admissions and for medical care and those sorts of things. but an analysis of what the appropriate volume of those vacant beds at each facility are necessary would be very valuable for the information for the legislature to have. And without that sort of information, it's difficult for the legislature to make an appropriate determination about whether this requested number of beds is the appropriate number. Our second concern is that this proposal is based on the department's ability to quickly and fully staff the new positions associated with the bed increases, but staff vacancy rates are quite high at all of the hospitals and psychiatric programs. And so these additional beds may remain vacant, for example, as some of the vacancies the department mentioned earlier, because there's not enough staff to provide care. So just kind of in summary, to talk about our recommendations, we would recommend rejecting the current proposal for additional capacity. And we would recommend that the legislature direct DSH to report at May budget hearings on the number of vacant beds that they have at that time, how savings related to those vacancies could be diverted to fund the requested additional beds, and what steps are being taken to address the vacancy rate, some of those issues they've discussed today. We would also recommend that the legislature direct the department to report in May on what progress has been made to expand some of the programs that we discussed today, for example, the Restoration of Competence program, which could affect their need for additional IST beds. And finally, we would recommend that the legislature direct DSH to develop a proposal to contract for an independent analysis of appropriate bed vacancy rates, staffing levels, and related factors for each of their standalone facilities and psychiatric programs. And I'm happy to take any questions on those recommendations.
Thank you very much. Members, do you have any questions for Elio? All right. Thank you very much. Public comment. Department of Finance, did you have any comments? I'm sorry. Thank you very much.
Okay.
Yes, please.
Good morning, Madam Chair. Corey Salzillo on behalf of the California State Sheriff's Association, here in support of issue 4, the 105 beds in the budget to address the backlog of IST inmates. As you've heard from the department and in your committee analysis materials, there is a backlog of IST defendants. When they are not being treated, they are sitting in a county jail decompensating usually. It's not good for the jail. It's not good for the defendant. It's not good for the process. To the extent we can address the backlog through additional capacity, get these folks treated, get them to a state where they can stand trial. I know you're familiar with the issues. We'd support the item as budgeted. Thank you very much.
Thank you very much.
Kristen Barlow on behalf of the California Mental Health Directors Association. Similarly, just wanted to mention our general support for building more expansion for IST capacity so that individuals aren't waiting in jails and are instead quickly accessing quality competency restoration services as fast as possible.
Thank you.
Kelly Brooks Lindsay on behalf of the California State Association of Counties. We're also in support of expanding the IST bed capacity. We would just note this is a really difficult population to manage locally. Thank you.
Thank you.
Randall Hager on behalf of the California Psychiatric Association. We support this proposal.
Thank you very much. All right. The recommendation for this item is to keep it open, pending additional information before the May revision as well. So moved by Senator Mani. Members, what's your pleasure? Three ayes. Thank you very much. All right. The next item, the Salinas Valley and Vacaville psychiatric programs. Welcome to the testifiers.
Good morning, Pam Allen, Department of State Hospitals. Okay, the update on the staffing and activation of DSH Stockton. We are happy to announce we opened up 2 of the last 5 units that remained vacant there on March 24th. Those are to serve the intermediate care patients. They're currently being activated at this point in time and have approximately 20 patients admitted to both of those units, is a size of 60 patients. We also are projected to open up one acute unit, which will serve 30 acute Coleman patients. That's going to be opening on April 21st and will remain with 2 units being vacant, 30 beds each. Those we are currently recruiting for psychiatrists. We have been successful in recruiting the nursing, psych tech, and multidisciplinary staff to activate those units. Again, those units will depend on getting psychiatry recruited. We've been very successful in that and expect some new recruits to come in July. So we're very hopeful those 2 units will be opened soon. What caused the Coleman referrals to increase steady in the recent years? And it's been pretty steady. We've been collaborating with CDCR. It just seems like their inmates are meeting the mental health needs. The referrals that we've been reviewing over the past years are appropriate referrals from CDCR to the acute beds and to the ICF. So we do screen those to make sure that we're not getting overly referred to and not have the space available. Those are appropriate. And then why is the administration backing off from the commitment made? What we do is, I don't think we're backing off from the commitment made to the blueprint. What we did was we assessed how we were activating the Stockton units and also the referral list that were growing at the time. And it was in the best interest of the patients that we serve from CDCR to go ahead and keep certain units open at Salinas Valley and Vacaville Psychiatric Program so that we can take the new admits off the list and keep the list down to a reasonable time frame. So that's what we've done. We've taken all the new admits into the new units at Stockton instead of transferring those from Salinas Valley and Vacaville. Otherwise, we would have had well over 200 on a pending admission list. So it was just assessing what was out there being referred and meeting those patients' needs. Currently, we're reassessing it. We do it on actually a daily basis, weekly basis, monthly basis to make sure that we are managing the referral list and getting those patients in timely. So we're looking at probably around 90 beds. We'd like to keep this open for the May revision so that we can have the most current data to give you to the remaining beds that need to be open. And we're working with CDCR on the same plan.
Okay, thank you very much. Legislative analyst?
Our comments on this issue are the same as our comments on the previous issue.
Thank you very much. Department of Finance. Members, any comments? This item, public comments. This item is recommended to be held open also so that we can get some more population data by the May revision, and it's moved by Senator Monning. Members, what's your pleasure? 3 ayes. All right. Next item, security fencing at the Patton facility.
Mark Beckley, Department of State Hospitals. We are in the process of building the new perimeter fence at Patton State Hospital. This hospital will improve security at Patton. It will have clearer lines of sight. There will be a double security fence. So we think that in terms of safety, it'll drastically improve safety at Patton. The overall project cost is approximately $15 million, and we're in the process right now of contracting with a firm who will do the architectural drawings and construction and produce a construction estimate. So the project is well in progress.
All right, thank you. Any comments from legislative analysts? Department of Finance? Public comments? This item's recommendation is to approve it as budgeted. Members?
I have one question.
Yes, Senator Monning.
The analysis indicates $4.8 million in annual savings due to reduction in security staff.
Correct.
That's based on the increased security provided by the fence allows you to reduce security staff.
That's right.
Yeah,
And
cleaner
by-
lines of sight, fewer posts needed for the correctional officers. So they are reducing the amount of correctional officer staffing that they'll need to secure the fence.
And do you know how many staff positions that represents?
Yes, I believe it was 56. Let me see. Approximately 59 positions.
And are those positions, is that net savings to the state, or will they be moved to other facilities?
Those are those are correctional officers at Patton. They have control of the outer part of the facility, and the savings will accrue to us. But I don't know what happens when. I assume that it will occur across the board, but it's not in our area.
I understand. Thank you.
All right. Thank you very much. Yes, members, what's your pleasure on this item? Oh, wait, public comments? Department of Finance, legislative analyst. Legislative analyst.
The only thing I would note is that CDCR annually goes through twice a year goes through a budget adjustment process, and the savings would likely be scored as part of that process.
Thank you.
All right, thank you very much. All right. Okay. No public comments? Okay, members, what's your pleasure?
Move to approve as budgeted.
Thank you very much, Senator Monty. Moved by Senator Monty. Members, everybody okay with that? Aye. 3 ayes. All right, thank you very much.
Thank you very much.
Agenda A. Thank you all very much. All right, we're going to move to Agenda B. Thank you, ma'am. Thank you very much. Hello. Can I ask the first panel to come forward, please?